Well, good morning or good afternoon, everyone, depending on your location nationally. I'm James Hodge. I'm the Peter Kiewit Foundation Professor of Law here at ASU's Sandra Day O'Connor College of Law and Director of the Western Region Office of the Network for Public Health Law. And welcome to our impactful webinar today, Navigating Legalities and Crisis Standards of Care. We've got a hot topic with a lot of repercussions nationally. We're looking forward to questions, comments, and thoughts. But first, my two co-presenters will work with us to actually get across some very good initial information on this critical topic at the intersection of standards of care in the throes of the pandemic. Oh, to be sure, without further introduction, let me be brief in how I introduce my two great colleagues, and then we'll jump right into our material. We've got so much to convey today. I'm so pleased and honored to be joined today by my two great colleagues here at our Western Region Office of the Network, Jennifer Pyatt and Erica White. Jen Pyatt is our research scholar here at ASU Law. She's also Deputy Director of our Western Region Office. You've seen Jen on multiple of these types of webinars if you've been with us over the last year or so. She's an expert in crisis standard of care issues, advises the national academies on these specific fronts, and will bring a very solid analysis to some of the core things we'll discuss. Erica White is also a research scholar with us here at ASU Law and one of our staff attorneys here in the Western Region Office. Erica has just arrived with us from Texas, where she's a licensed practitioner and has joined us just recently, but I assure you has outstanding material to share with us on the actual impacts of COVID-19 at the intersection of crisis standard of care. Without further ado, let me give you a sense of what we can accomplish in our opening sort of assessment. I'm going to try to fill you in a little bit just briefly on what we all know, but really have got to be just glued to specifically related to crisis standard of care, or CSC, as we'll consistently refer to it, in concept and in practice. What are those sort of issues that we're seeing throughout this pandemic and currently with Omicron threatening that really are starting to play out, giving us an opportunity to assess the legalities closely. I will then turn it over to Erica. She'll walk us through some of the most pivotal issues with COVID-19 at this point in time. And then we'll turn it over to Jen, who will actually walk us through very critical legal observations that we've made, not just with the challenges around legal triggers for CSC or regional coordination and discriminatory impacts, but also solutions legally to how we're actually thinking these things through in real time, even in the throes of one of the worst parts of the pandemic. I'll turn it back over and take on tie-breaking decisions. We'll talk a little bit about post-COVID. Yes, there will be a day where we're beyond COVID crisis standard of care issues. Your questions, your comments are highly sought. Here's the best way to communicate those to us. Don't wait for the specific moment. If you have a question or comment, put it into the Q&A function here with Zoom. Go ahead and type it in at any point in time. Erica's monitoring that very closely. We will take all questions toward the end, right at the end as we conclude our initial opening comments. And to that end, we'll look forward to every question and comment you have, and others we can't solve. We're committed to working with you later to try to find those answers. All right, without further ado, I was on board originally in 2009 when through the Institute of Medicine, we set out this sort of concept of crisis standard of care. And in 2012, we perfected that concept with a toolkit for indicators and triggers through our Institute of Medicine committee led by our great colleagues, Dan Hamfling and Larry Gostin and others. That committee's work towards where we stand now has been so pivotal towards defining what we mean by crisis standard of care. That definition is what you're seeing at the top of the screen. It's that substantial change in usual healthcare operations and level of care due to a pervasive or catastrophic disaster. That's our working definition. That's what you're seeing happening across hospitals all across the United States, not just right now in real time, but for the last 2 years because of COVID-19. What you're seeing here constantly being weighed in these specific settings is what you're seeing on screen. We're weighing patient and population demands. They are outweighing what we have in crises available through ICU or beds or PPE or healthcare workers, meds or capacities. When patient demands outweigh what we can provide in standard operations, you're shifting into crisis, especially when it's sustained like during a pandemic. I like this definition at the bottom that I kind of use as my pocket definition. Hey, when sustained scarcities warrant real-time resource allocations to protect the public's health, you're in crisis. It is time to make those critical adjustments. You're talking about shortages of things that matter in the healthcare delivery sector: space, staff, stuff. When this stuff runs short at any juncture in regards to sustained events like COVID-19, you're shifting into crisis standard of care. What and how the committee originally through the Institute of Medicine, now of course the National Academies, thought this through in sort of this illustration couldn't be more pivotal to our observations today, because what we thought through on that committee was two major foundations for which all of crisis standard of care rests. Ethical considerations, so critical. And while not a subject matter for us to discuss here, legal authority and environment. What does the law actually allow, and what will it let you do in real time in response to the types of crises we see? It's so pivotal on all of these particular issues. The toolbox of what's available to us in real-time emergencies, especially when we see declarations, as Erica will talk about, across the United States for months on end, are really quite profound. We can use executive orders, statutory waivers, regulatory waivers. We've got licensure reciprocity provisions at work, scope of practice adjustments, nurses doing things they can't do in non-emergencies right now, expedited procurements, getting the supplies and resources we need in real time. We can take property we need via government, reimbursements up to a due and different level. I'll tell you the one that always gets a lot of attention, of course, is liability. Who's liable for implementing a standard of care that doesn't look or assimilate what most patients and a lot of practitioners would understand to fit the needs of what specific patients have in mind? Who's liable, under what circumstances? Gosh, nobody, not a healthcare practitioner, not a hospital, no healthcare entity wants to find themselves in this web of potential liability risks. They're out there, they're profound, and the ways in which we respond to those liability risks have been pivotal throughout the entire course of this pandemic in response to CSC. Let me give you a little nutshell of what you're seeing on screen, and then we'll convey right into the sort of phenomenon we're seeing presently with Omicron and its impact on hospitals. There are two approaches to take as you shift from conventional to contingency to crisis standard of care in relation to liability risks. You can follow that sort of evolving standard like you see in path one. Just follow along in whatever standard you're meeting, so long as a healthcare worker or a hospital is meeting that standard, technically they shouldn't be liable. But that's not enough, say healthcare practitioners, nor legislators, nor policymakers. Path two says that's not good enough. We need to provide enhanced liability protections for healthcare workers and entities. That's exactly what you're seeing in real time during this pandemic. This is what we've established, this umbrella of liability coverage, with a lot of different drop downs at the federal, state, and sometimes even local levels, all of which are designed to provide liability protections to healthcare workers, volunteers, and entities for their various different acts of what might be considered negligence, otherwise not intentional misconduct, but if it's acts of negligence, so long as you can find yourself fitting under this umbrella, whether you're a healthcare worker, a volunteer, or a hospital entity, you've got some liability protections that are beyond what you normally would see in other non-emergency events. That's so critical and invaluable towards executing and implementing crisis standard of care. But you know what? We're at that moment in time, again, with COVID-19, where crisis standard of care is literally on trial. Let me share it now and take you over to Erica to actually take us and walk us through some of the really critical moments and pivotal data that we're seeing right now with COVID-19 to help us set up and explain those specific phenomena. Erica, over to you.
Thank you, James. So now that we've seen an overview of what crisis standard of care means, let's turn to COVID-19, the deadliest disease in US history. These numbers you can see on your screen are from this morning. Globally, we're at 338 million cases and 5.5 million deaths. The United States makes up 20% of these cases, even though the US makes up 4% of the world population. And similarly, we lead, quite unfortunately, at 15% of deaths. Next slide, please. Legally, we have done everything we can to combat the COVID-19 pandemic, with the most extensive use of emergency powers ever utilized by federal, state, and local governments. We'll look at state action momentarily, but here on this slide, we've illustrated the immense powers the federal government was able to access in the earliest days of the pandemic. In early 2020, former President Trump with department heads, notably HHS Secretary Alex Azar, declared various levels of federal emergencies, beginning with the Public Health Emergency Declaration in January 2020. To access resources, including National Guard troops, additional emergencies were declared into the spring of 2020, and all of these remain in effect today under President Biden. Next slide, please. By March 2020, every US state had declared its own version of a public health emergency for the first time in US history. Governors were able to change the legal landscape and implement policies to protect residents from harm stemming from the COVID-19 pandemic. Since the first issuances, we've been tracking these declarations in real time, as you can see here on this slide. where we've indicated the type of emergency states have declared, the date of that declaration, and if that declaration has been rescinded or even redeclared. Today, about 20 states have rescinded their emergency declarations. But in light of recent Omicron surge, some states that rescinded their emergencies have actually redeclared in order to regain access to critical resources. Next slide. And again, in the earliest days of the pandemic, when governors were first declaring emergencies, we did not have COVID vaccines. But since December 2020, states have been focusing on rolling out vaccinations to residents. The vaccine rollout isn't over, but it's stalled at around 63% nationally, as you can see here. Vaccination rates vary around the country, as you can see with the different colors of green on this map. Much of this variation can be attributed to state governments' varying approaches to combating the pandemic. Next slide, please. In what we have been calling the COVID-19 denialism playbook, some state governments, via legislative challenges and judicial invalidations, have taken action to change pandemic response mid-stride. As you saw in our last slide, some governors have rescinded their emergency declarations, even as some have reopened economically, banning mask and vaccine mandates and shunning social distancing efforts. Forcing their doors open, other states have forbidden schools and businesses from closing, even as illness among workers and students empty the halls. And what we know is that when state governments follow the denialism playbook, infections increase exponentially. Next slide. And all of this is compounded by high ICU bed utilization. In some places in the United States, hospitals report being at near capacity. This map here reflects data from days ago, but isn't it reminiscent of the earliest days of the pandemic? Full ICU beds mean more patients have to be transferred and rerouted, but medical staffing and resource shortages make this difficult, resulting in needless loss of life. Next slide. COVID-19 infections today are the highest they have ever been. Last week, I believe we reached that record high. Today, we're seeing a slight dip in infections, and some experts have speculated, hopefully, that the Omicron surge has peaked, but others remain hesitant to declare victory, especially given the crisis we're experiencing thanks to those shortages. Next slide, please. And those shortages are severe. Against the backdrop of the extreme uptake in COVID-19 infections, hospitals have been struggling to meet the increased demand. And data shows that when hospitals are overwhelmed, more COVID patients die. Here on the screen, we've collected just a handful of headlines from news sources across the country, but there are a seemingly endless supply of these headlines reporting the dismal current state of US hospitals. Nurses are completely overwhelmed. Led by labor unions, they've been protesting these conditions. Pediatric hospitals are at record numbers. Pediatric hospitalizations. Cases among nursing home residents are close to peak 2020 numbers. Hospitals experience crippling labor shortages, including food service, supply chain, and equipment repair. And these conditions have led to a number of hospitals activating or reactivating crisis standards of care. So now I'm going to turn it over to Jen to explore some of the major legal challenges surrounding CSC.
Thanks so much, Erica. Next slide. So indeed, the impacts of COVID-19, of the Delta surge, of the Omicron surge have been staggering. What they've highlighted on the CSC front are a number of complicated legal issues involved in implementing and executing CSC. Many of these issues can be and have been addressed, at least in some part, through emergency powers made available at local, state, tribal, or federal levels. But four key questions really remain. The future of CSC implementation necessitates solving these legal challenges. And these legal challenges arise in terms of legal triggers for CSC, regional coordination of implementation of CSC, discrimination in implementing CSC, and legally making really difficult tie-breaking decisions. Next slide. So let's take on that first issue, legal triggers. Now, CSC can't really be effectively operationalized without understanding what legally actually triggers it. During the COVID-19 pandemic, only a few select states displayed on the slide before you actually expressly invoked CSC statewide through emergency or executive order. But what about all of the other states that are not represented on this slide here that undoubtedly experienced crisis circumstances at some point during the pandemic and often repeatedly during the pandemic? Without state invocations of CSC, how can healthcare workers and others be actually sure that CSC is in play, has been legally invoked. Next slide. So the key to understanding all of this is to understand the definition, the circumstances defining crisis standards of care, and not in any particular declaration. This is really critical. CSC is definitively triggered when a sustained scarcity of resources accompanies patient surges in emergencies. In this kind of environment, the normal standard of care simply cannot be sustained. And that is what triggers the shift into CSC. The declaration does not shift into CSC. The circumstances shift into CSC. What the declaration does is makes it easier to implement CSC because of the powers that that declaration provides. Next slide. Just to give a few examples of what we're talking about here, we've identified several other legal sources for invoking CSC beyond a clear formal state declaration invoking it, expressly stating CSC is in place. Now, this slide demonstrates several distinct options, including federal guidance, use of regional agreements, including the Emergency Management Assistance Compact, or even healthcare entity-specific allowances that might be built into state plans. We've also provided examples of all of these occurring because, again, CSC doesn't depend on a state declaration. It depends on the circumstances, but can be facilitated or more easily carried out when accompanied by any of these distinct options. Next slide. And to kind of make this a bit more clear, let's take a look at some available emergency powers made possible across three distinct menus: state emergency declarations, regional agreements, and the federal PrEP Act. So several of the important enabling emergency powers you can see across the menus are the same: licensure reciprocity, statutory and regulatory waivers, which help to alleviate any sort of limitations in the way of carrying out CSC, liability protections for healthcare workers. These powers all make it much easier to implement CSC, and they can stem from any single one of the menus presented on the slide. Now, some of the menus also have other items in common, like scope of practice expansions or telehealth expansions and expedited procurement powers. Some of the menus have their own distinct options, like the broad preemption available to the federal government under the PrEP Act. But what's important to acknowledge here is that any one of these menus on its own provides specific enabling mechanisms for carrying out CSC. CSC can be facilitated or more easily carried out when any of these sources or other sources, as identified on the previous slide, are implicated. But those working under CSC must be able to adjust their actions for what they are legally authorized to do based on which of the menus is at the table in a particular setting or emergency. Next slide. Now let's turn to the second issue, regional coordination. Regional coordination across public and private sectors is absolutely necessary to promote uniform applications and understandings of CSC. We've witnessed throughout the pandemic patient surges occurring in some medical centers while others close by had plenty of room and supplies. In attempting to address failures of communication and data sharing, the federal government initially struggled to implement a single uniform data system to help provide transparency of where those available resources were located. And individual facilities adapting to that then struggled themselves to work within moving goalposts while still attempting to treat wave after wave of COVID-19 patients. So legal challenges arise here because of widespread variations in the jurisdictional definitions of emergency, of crisis standards of care, of triggers for execution. Our federalist system enables states to act independently in their own spheres, and states did exactly this in taking on CSC planning and implementation. They acted without uniformity, they acted on their own, defining and implementing CSC on their own terms. But this resulted in mismatches across jurisdictional boundaries against a pandemic that completely ignores them. Next slide. So there are a few solutions to increasing coordination in the future. The first is a state-specific development out of Arizona, my home state, which developed a state surge line. The governor required all hospitals to use this specific surge line for the transfer of COVID-19 patients to available beds across the state. You can see that map of just all of the transfers taking place on that slide before you. Thousands of COVID-19 patients were successfully transferred through the line. And this forced that public and private coordination across jurisdictional boundaries within the state of Arizona. Now, Arizona's approach was implemented on an emergency basis, but in the future, states might take these kinds of actions preemptively before the emergency strikes. Next slide. Now, at the federal level, several different mechanisms might prove useful. CMS and FEMA, for example, federal agencies that can provide funding for participation in federal programs, and they can then condition that funding on fulfilling certain requirements, which could in turn facilitate further cooperation, further uniformity across jurisdictional boundaries. The establishment of medical operations coordination cells, or MOC cells, proved useful in some states like Washington to help load balance COVID-19 patients and ensure the highest level of care possible. Finally, legislation like EMTALA seeks to promote coordinated responses and ensuring care for patients, while additional legislation in the future could help ensure greater uniformity for things like data collection, and could help further address disparate impacts across populations. Next slide. So speaking of these disparate impacts, we saw article after article after article published during the COVID-19 pandemic, proving that certain populations have suffered clear and irrefutable disparate impacts. And these are just a handful, there are many more out there. But some of this is actually attributable to CSC plans themselves, and that must be corrected if plans are going to be used efficiently and equitably in the future. Next slide. So let's take a look at what we've seen in terms of the federal civil rights enforcement sphere coming out of the Department of Health and Human Services Office for Civil Rights. They resolved a series of complaints against state CSC plans throughout the COVID-19 pandemic, alleging that the plans included discriminatory criteria. Largely, HHS OCR's focus was on age or disability-based discrimination. But beyond this, other populations face disparate impacts as well. Persons experiencing low incomes often found themselves at underfunded facilities. And in some cases, those underfunded facilities faced heightened death rates, treating many more COVID-19 patients than larger facilities did. Judgments made incorporating long-term survivability negatively impacted persons on racial lines, as Black populations generally have a lower life expectancy than white populations. And so in assessing these impacts, we've developed this high-level summary of sort of a red light, yellow light, green light scenario to take forward in crafting and updating CSC plans ahead of future emergencies to avoid, as a red light, categorical exclusions of specific populations, exclusions based on discriminatory impact of colorblind policies, to be wary of diagnostic tools which are facially valid, but which can be applied in a discriminatory manner, and to utilize tools which anticipate discriminatory outcomes and which adjust to try to avoid them. Next slide. So avoiding these discriminatory impacts requires deliberate incorporation of principles of health justice to ensure equity. In October 2021, the Presidential COVID-19 Health Equity Task Force issued a final report and recommendations highlighting specifically what the federal government should do for purposes of equity in CSC moving forward. Some of these recommendations include convening a panel to update NASEM's CSC guidance, disseminating standards more widely, and potentially incentivizing adherence to them through reimbursement or accreditation requirements, and supporting research to better understand the disparate impacts of state plans. So we're certainly watching to see what changes may arise at the federal level based on these recommendations. Now I'll turn it back over to James to take us through the final critical legal issue we'll discuss today, legally making those tie-breaking decisions under crisis standards of care. James?
Great, Jen. Thank you so much. Such great information. So many challenges, but also solutions. We hope that's starting to become for you all something that's pervading our assessment is we have opportunities legally to address these things. Being smart about them in real time is what we're talking about. And there could not be a more dynamic environment in which you've got to be smart, fast in relation to the legalities. That is when you're dealing with tie-breaking related decisions. Now, what you're really seeing on screen is what's happening in a lot of hospitals across the country throughout this pandemic. It can come down to this. You got a vent and 12 people that need it because of COVID-19 related complications. Does it always come down to that? No. Could it be 2 people? Yes. Could it be 5, 6, 10? Somebody on this screen could use that vent, but you got 1 to dole out. How do you make those critical, tough choices? Who gets the vent on screen? Okay, now, from a medical perspective, we're highly deferential to medical professionals doing everything possible to make that determination. And it's on ethical perspectives. We're highly deferential to ethicists drawing tough lines about how you make these decisions in an equitable way. But legally, how do you avoid potential tripping points? Well, let's be sure. Everybody knows to avoid this. You don't make those decisions based on disability or based flat out on age. That patient's older, this one's younger, she gets it, he doesn't. No, you don't get to do that. We know there are provisions against that. Jen talked about some of those critical things that HHS OCR has mentioned to us. Race, obviously, don't make it. It's not a factor. Sex is not a factor with COVID-19, to be sure. All of these things are obvious to us, but do you realize legally what else you cannot use as a basis for making those tie-breaking decisions? We've looked across the country at a lot of CSC plans and a lot of laws and policies. And what you'll start to see across the United States are all of these bulleted various different reasons and things that in one legal form or another should not be used in the federal level or across a particular state to make these tough decisions. Look at all these factors: veteran status, marital status. Don't use sort of advanced planning or steering decisions. Don't make categorical decisions. Watch out for the inequitable clinical assessment scores. Against this backdrop and knowing that these are the sort of legal factors not to be utilized, honestly, you almost wonder what's left. This is what states in a lot of their CSC plans have promoted as what's left. If you're in that tie-breaking scenario, some states' crisis standard of care plans literally kind of list these sort of first or second level criteria to use, as if these will help you make those critical choices. Who's pregnant? Give the vent to her. Who's a minor? She gets it first. Whatever prior allocation. Did we give it to the older gentleman a day ago? Well, he gets to keep it until further notice. No questions there. Who brought the actual vent in? Did somebody bring the ventilator equipment with them to the hospital or other type of respirator equipment? If so, they get to keep it. First come, first serve, some states say. Got here first, you get it. Lotteries, pure SOFA scores, life cycle, social order related issues, SVI scores. This gets even harder to ascertain legally. When or how do you make those good judgments about who gets that last vent in those tie-breaking scenarios? And I keep honing in on vents. It could be any number of different types of things. A particular medical drug that you may need to pass out, a particular access to healthcare workers or an ICU bed or otherwise, making those tough choices. We think these are defensible categories. Here are the go-to moments where you may legally be able to at least trust that the basis on which you're making tough, tie-breaking decisions could be sustained legally. First, you're relying on specific resource limitations or suitability. If you've got a resource that's only good for adult patients, obviously you don't apply it to a pediatric patient because it's non-useful there. That makes sense. Legally, you can go for it. Current medical or public health information. Yeah, you get to rely on that. What are the current extant pieces of information about COVID and its trajectory with Omicron right now? If it shifts and changes epidemiologically, you can shift with it. You use individualized patient assessments. Do not apply uniform blanket criteria across a population of patients. OCR is all over that, and for good reason. When you can make those medically driven patient assessments, you will often find some of those tie-breaking decisions get a lot easier. Objective medical evidence, equitable clinical assessment scores. You may use short-term survival, but not long-term survival. Long-term survival implicates way too many age and potentially even other race-related discrimination issues that Jen talked about. You can use age only as a limited prognostic factor. Patient surrogate consent and choices, who's consented to specific withdrawal of care, that happens. And to be sure, you can respect that. healthcare worker status, these types of criteria coupled with appeals, opportunities to revisit and assess who got what and under what circumstances. The winner today gets the vent. The losers today get reconsidered tomorrow. Those appeals processes so critical. So as a result, wrapping up our discussion and entertaining an opportunity in the moment to go ahead and put into Q&A any questions you've had at any point during the presentation. Erica's monitoring for them closely. Jen, Erica, and I will all take them on in just a second. There's a day, I hope it's soon, I think we all do, where COVID will be in the rearview mirror. It won't be gone. It's going to be with us for quite some time, but it will not be the public health emergency phenomenon that we've all experienced over these last 2 years. And to that end, we'll say, whew, crisis standard of care, we're done. Oh, we're not remotely done. And we know it in the healthcare and public health arenas. The balance will shift between all those hundreds of thousands of non-COVID patients who had their demands and needs for sort of alternate surgery or surgery that could be done separately or later or at some other moment. They're going to be swelling the healthcare sector. They're going to be looking for interventions. And how are we going to manage them? Are we going to have a new type of crisis of all those patients put off by COVID-19? Oh, it's quite possible. And what we're balancing at that point is who's available, under what circumstances, and in what line are non-COVID patient demands going to be dealt with systematically. We've got a lot to learn as what we pulled away from this pandemic. But I'll tell you one thing that's going to be an interesting legal factor. It's a very different legal scenario when you're having to make tough allocation decisions about what care you provided on the left side of the screen. I mean, these healthcare workers are providing specific care. They had to make tough choices. There are legal issues around that, but gosh, some of those legal issues we've shown you right now can be resolved. It's the omission of care. Who didn't get care for the last 6 months because of COVID? What issues legally or from a liability perspective come out of that? Oh, we'll be watching that very, very closely in these months ahead, because how we distribute those healthcare services in an equitable, sort of systematic way to all the hundreds of thousands of patients who got put off for care for some period of time, whether they self-elected that or healthcare sectors had to tell them we put you off for this period. It's going to be very interesting to see legally. We're already working toward how to map and think that through in real time ahead. All right, without further ado, thank you for your patience and attention. We're going to turn it over now to Q&A, and I'm actually going to send it right back to my great colleague, Erica White, who will take us into some opening questions and comments, which Jen, Erica, and I will try to address for you in real time. Now, Erica, back to you. What are you seeing already in Q&A that's shown up?
Thanks, James. Yeah, we have a great number of questions already for our audience. So first, going back to one of our first slides that you showed us, if legislatures don't pass bills to provide enhanced liability coverage, do governors have the authority to provide protections by executive action?
Oh, yeah. Would you like me to address that? I know Jen's got good stuff on that too, but I'll tell you straight up, whoever asked that question, it's a good one. And yeah, they do. It can have limits, but what some governors have done in regards to their express executive orders, they've done two things during the course of this pandemic. First, they've actually put out there straight up, we offer liability protections currently. I believe Governor Larry Hogan recently did that this month in January for the purposes of reinitiating a declared public health emergency in the state of Maryland. Other governors have followed suit, but they got another pathway that's also really cool and available to them legally. They can waive existing liability routes. Such an interesting power of governors. During declared emergencies, in most states, governors can waive laws that conflict with emergency response. And if a liability theme or avenue that might be otherwise available is conflicting with how healthcare workers can respond in real time, governor can waive that. Governors have done that. It's been an interesting route and phenomenon. Jen, anything you add to that analysis? Anything you've seen or thought through nationally across the states?
I think that's a great analysis of it. I don't have too much to add, except that I would say that the waiver of provisions limiting licensing and of provisions limiting healthcare workers from practicing in states potentially where they're not licensed, that can also play in here as well, where normally you'd potentially have liability arising, you'd potentially have discipline arising from state boards of medicine for practicing without a license in the state. Those powers, those emergency powers do allow for waiver of those licensure requirements. And we saw that invoked on a grand scale during the COVID-19 pandemic. So yeah, these powers, they do differ from state to state, but they certainly enable a broad sweep of actions to deal with the emergency.
Right, Jen. And I'll tell you one additional add-on to that, Erica, and then we'll take that next question, is the following. Remember that slide I showed you on the umbrella? How do you fit under it? Being creative and understanding how you as a healthcare worker or entity or otherwise fit under that umbrella is a big part of what we can help to show. Now, while we can't dispense legal advice to that effect, we'll give you good information about how that analysis works and what those various different avenues are. So I'd invite that person who asked, if you want to email us, any of us on screen, and we'll try to follow up with you later with more information to that effect. Great stuff, Erica. Got us off to a good moment. What else are you seeing?
Absolutely. So given the likely moral distress experienced by healthcare personnel under CSC, what happens if a clinician doesn't conform to these CSC requirements? Meaning if they continue to care for patients as if we weren't in CSC?
Great question. Jen, thoughts, comments to start, or would you like me to take it on initially?
I think we're probably going to say something similar, which is when CSC is in place, there is a risk of liability for not conforming to that CSC, because that is the applicable standard at the moment. That is the standard that is in place in order to save the most lives. That is the standard that would be expected. And so liability could certainly arise if there is a certain standard in place that is not then adhered to. James, do you have any additional thoughts to add to that?
Yeah, Jen, so true. But I'll tell you one thing that let's be very clear on. To all healthcare workers out there nationally, struggling against the backdrop of what COVID has thrown at us over the last 2 years, and especially with Omicron, including so many thousands of preventable infections because of vaccination status that, if improved, as Erica noted, would make such a difference. To all of those healthcare workers doing laudable, heroic work against that backdrop, we know the tough moral choices that you face. The legal environment in which you make those tough choices, we think is as agreeable in some jurisdictions as you can possibly get, even against the backdrop of how federal PrEP Act protections may apply in specific settings too. But it does not relieve the moral distress. We know that for sure. And obviously, there's nothing legally we can do to actually take away that moral dilemma that every healthcare worker having to make tough choices, tie-breaking choices at times, although very much at the hands of triage committees within hospital settings. It impacts healthcare workers, doctors, nurses, and others. And to that end, smoothing or paving the way for at least having a viable, reliable, trustworthy system for at least making those tough CSC choices. That's what we think we can put into place legally that hopefully it benefits down the line as well. Erica, such good, poignant questions. What else are you seeing that we can address?
Yeah. So how would CSC apply in the real world to be invoked in defense, perhaps several years in the future? Would we look to COVID shield laws, CSC declarations in place, or if CSC was put into place retroactively?
Interesting. Jen, it sounds like a trigger question. Do you want to address that initially?
Yeah, absolutely. I think it certainly sounds like a liability protections question as well. And you know, when we're talking about liability protections, we're starting off with the assumption that we're in some form of litigation. And in some form of litigation, you're going to have the arguments come out, and the arguments will come out if there was, for example, an emergency declaration or some other form of order that provided for liability protections at that moment. That's going to come into the litigation and argue that this is a bar to liability in this situation. And similarly, if you have, you know, not that express liability grant from a state executive order, there may come into question the applicable standard of care at the moment. And that is the other piece of, that's kind of the other pathway that James was sort of pointing towards, that you could make the argument that you are in a particular circumstance at the time that this decision was made. This is the standard of care that was in place at the time of that decision. Now, of course, I think this question acknowledges that that can be difficult, years removed from the time when these actions took place.
Great points. Oh, go ahead.
Yeah, I was just going to say documentation can certainly help with that, but we certainly acknowledge that that is a difficulty, and that's why I think, James, you were acknowledging that the other pathway of express liability protections can help make it much more comfortable to carry out those actions.
Jen, great points. My apologies. I was not trying to cut you off for a second. Such is the nature of Zoom. I thought I saw that pause moment. Let me interject with one other observation, highly consistent with what Jen just offered, and so relevant for healthcare workers. To follow path one, to actually prove that you met the crisis standard of care during the course of that emergency, 18 months later, does have one very big pitfall or downfall. You got drugged into court to do it, or you had to go into deposition to prove that out. You see, Path 1 has that facet to it that no healthcare worker, I think, initially wants to be challenged on in regards to the really tough, critical choices that they know are not always in patients' best interest. But during the throes of an emergency, crisis standard of care is about what's in the public health interest. How do we save the most number of patients against the backdrop of not having enough resources to save everybody that we could possibly want to against those specific circumstances? That's where Path 2 comes into play. When you get that immunity status or that indemnification status that arises through some of those specific liability protections, you gain the benefit of at least knowing a lot of the claims simply won't be brought, or they'll be settled quickly, or you won't be finding yourself before a courtroom or a deposition having to demonstrate what you did or did not do in real time, because so long as you acted consistent with that crisis standard and in a non-intentional, harmful way directly to patients, you're going to very well, if you fit under that umbrella, be able to walk out without the damage of having to be questioned within that legal setting. That's the goal so many policymakers at the federal and state level have put into place during the throes of the emergency. Erica, such great questions. What else are you seeing?
These are great questions. So next, what about patients who've refused to get vaccinated versus patients who are vaccinated? Can you make tie-breaking decisions based on vaccination status?
Oh, I knew that might come up. And I'm not laughing because it's funny. I'm laughing because it is starting to dominate triage committees in hospitals across the country. And I've heard that question more often than I'd like to during the throes of this last emergency sort of escalate of Omicron-related cases. We know these cases are preventable. If people were vaccinated at a greater level in the United States, we'd have a lot less hospital admissions related to COVID-19 and a lot less infection, because it's been proven over and over through CDC and other guidance across all the states, vaccines work and they're safe and they're efficacious. And gosh, if just more Americans would find the opportunity to take them, that will work really well. So can we use that factor as a criteria for dispensing that vent, for allowing that patient to just sort of disperse not just another COVID patient who was vaccinated and had a breakthrough infection? Can the non-vaccinated patient be put aside in favor of a non-COVID patient who needs access to the ICU? These questions are coming up nationally. I'll tell you, ethicists out there are starting to opine on this quite extensively, including our great colleague, Dr. Matt Winnia in Colorado, who's worked so closely with the National Academies. Great respect for Matt and everything that he's done. He's come out many times and said, don't use it as a criteria ethically. It's just trouble. When you start making distinctions of patients around their vaccination status over something they weren't in some states even legally required to do, like in Texas or Arizona, no mandate there that our governors have put into place. And so consequently, don't use it as a factor. I get that ethically. Legally, though, could you do it? Legally, to the extent to which it enters into the equation for the purposes of breaking ties, you do run the risk of that being viewed very negatively. Let's be really clear about that. Disability-related protections around that, other concerns extensive to that, and the sheer fact that you've got a lot more patients who are unvaccinated with COVID than otherwise. But I will say it's still coming up in specific triage environments, and we may very well see before the end of this pandemic that big legal case in which that is demonstrated as a factor of which will be under challenge. I don't want to predict what the outcome of that may be, but I will say ethically and legally, it does raise alarm bells. Erica, such a poignant question and a tough one we know is happening across the country. Jen, anything you wanted to add to that analysis?
No, I think you're spot on. I agree. And we're, of course, continuing to watch for potential litigation arising that would involve these kinds of questions.
Tough sledding for sure. Erica, your one slide where you showed us, still 30%, almost 35% of the nation willingly not vaccinated for this specific condition. A lot of those persons who are showing up still across the United States in all the ICU beds and otherwise. Such a value point. So any additional questions to offer us, Erica?
Oh yes, I'm sorry about that. Okay, here's one for you, Jen. So it seems an underlying CSC issue is how we address the structural inequity in the healthcare system that creates the need for this decision making. So how best to incorporate that into the CSC developing or update process?
Absolutely. That is, I think, key, and that is something that some states have actually started to do. And so a specific example, which we've talked about before with some of our medical colleagues, is the use of SOFA scoring. So SOFA scoring, the sequential organ failure assessment, that is incorporated expressly into a ton of state CSC plans as a basis for making determinations on survivability, and as a basis for allocations. And the research that has come out throughout the COVID-19 pandemic has indicated not only that SOFA is not a very useful metric for the kind of illness that COVID-19 is, but also that it involves disparate impacts on Black patient populations, because Black patient populations have a higher incidence of chronic kidney disease. And so they have elevated levels of creatinine, which is a factor in the SOFA assessment score. And so what we are starting to see, Massachusetts, for example, is a state that reassessed its CSC guidelines in light of this information. And what they did is they continued to incorporate the SOFA score in that plan, but they have built in express language stating that this should be limited for persons with chronic kidney disease in order to address that inequity and in order to prevent that from continuing to exacerbate that inequity. So I think, paying very close attention to the data, making determinations based on that data, and being able and willing to change when that data appears in order to ensure that we're moving forward in a direction of equity as much as possible. Erica, I'll turn it back to you.
Okay, great. Thanks, Jen. So going back to our tie-breaking discussion, in terms of tie-breaking decisions, what is considered short-term survival and what is meant by healthcare worker status?
Got it. Okay, short-term survival means to the extent to which you're using it for the basis of a tie-breaking decision because a patient's survival rate up to or just after hospital discharge is not favorable, because of all the factors that we've been talking about, and ones of which were deferential to our medical authorities out there for making those tough choices. But the reality is, if that patient's short-term survival is lower or less possible up to that point of hospital discharge or just days or so after, you may take that into consideration. Of course, if the patient has a very low chance of survival for all the factors you've already assessed, and another patient doesn't, they both could use access to the vent, make a decision based on that medical criteria. Legally, you can pull that off, I think, very well. And then the other issue, Erica, was, I think, related to healthcare worker status, right?
Yes.
Got it. Thank you. We're talking expressly about what a lot of states have built into their CSC plans. It's ethically what we call reciprocity. And it's built around this simple phenomenon. If you're a healthcare worker and you're putting yourself and your family at risk and lives on line to provide the type of laudable, valiant service that so many healthcare workers are doing in the throes of this emergency, it may legally be defensible for you, the healthcare worker who fell ill to COVID-19 and may be in line for access to a limited resource. It may legally be defensible for you to get access to that resource in and above others, because you have done or participated in a specific way that actually puts you in a position of great risk of harm. And the benefit of that legally and ethically is to suggest, if you find yourself in that specific role, we may sort of launch you to the top of the list in relation to it. But there's a lot of other factors here. It's not the sole decision, it's a factor. With that said, there's also one other reason for the purposes of reciprocity. And from a legal perspective, it makes a lot of sense. We need that worker back again. We're obviously against the backdrop of COVID-19. We need every hand we can get. And if that means we save that nurse or doctor from potential pitfalls related to their health condition that they sort of arose because of their exposure to COVID-19, treating patients, there's a net good for all of us in that specific analysis. Legally, you may be able to enter that into your equation. Ethically, it's standard for the course in relation to how we make those tough choices. Erica, I hope that explains that well. I know we're drawing close on time. What are the sort of great questions are we seeing?
Yeah, great, thank you. These next two kind of go together, so in interest of time, I'll combine them. But speaking in terms of medical malpractice, will invoking CSC without a grant of immunity limit malpractice liability as the governing standard of care? And then in terms of med mal cases, what do COVID shield or CSC trigger laws protect against explicitly?
Got it. I'll try to handle one part of that. And Jen, you comment as well. And Erica, throw in your 2 cents worth there as well. One of the things that those specific protections do is not change, the fact of which there may have been negligence that underlied the delivery of specific care. A specific jury or other fact finder may say those healthcare workers, they were negligent in how they actually, distributed those resources or apply them in real time during the throes of the emergency. That decision, you may say, did not meet what we might consider to be the sort of negligence standard. But you know what? During the throes of the emergency, pursuant to all of those liability protections, we're not going to pin that on healthcare workers. Why? Because the tough, difficult choices you have to make in real time, where literally the standard of care is fluctuating with available resources and patient surges and demands, are so profound that the legal policy that you're seeing there is not to dispense with medical liability and say it doesn't exist. It is to say we are recognizing its potential and we are releasing from liability those healthcare workers who act potentially what we might view as negligently. They're released potentially, not if they act intentionally or in a grossly negligent way. And if they did engage in that level of behavior, of course, they're culpable for that. But that's the nature of it. That's the critical legislative and policy choices made across the country on so many of those specific fronts. It's not designed to insulate healthcare workers engaged in egregious behaviors. It's designed to help them make those tough choices, knowing the impacts on patients might otherwise be viewed as negligent outside the emergency. Jen, anything you'd add to that in relation to PrEP Act or other potential liability protections out there, and even some of the ways persons like patients who are harmed still have recourse, notwithstanding no direct liability against healthcare workers?
Yeah, absolutely. So the PrEP Act has been invoked via emergency declaration for the entirety of the COVID-19 pandemic. And the PrEP Act provides specific liability protections for covered persons, including healthcare workers, who are employing the use of COVID-19 countermeasures. And those can include things like the COVID-19 vaccine, which there's a lot of talk about that when the COVID-19 vaccine was still only under emergency use authorization and not fully approved. So the PrEP Act does provide very broad liability protections when those countermeasures are being utilized. And we are starting to see some litigation in some federal circuit courts about just how far that liability protection goes. So we'll be continuing to watch that and potentially providing key updates on key cases regarding that. But in terms of the other piece of your question with respect to persons who still are injured, potentially by a countermeasure, and how do they obtain recourse? Well, there is the Countermeasures Injury Compensation Program, or CICP, which allows for injured persons or others on their behalf who act on their behalf to file claims to the federal government to ask for compensation for those serious injuries that potentially were inflicted. So there is not a complete line of no available recourse. There still are some available sources there.
Great, good stuff, Jen. Thank you. Erica, back to you. Maybe time for 1 or 2 more quick questions.
Yeah, and here's a great one. So with federal guidance advising states to convene multidisciplinary panels to update CSC per equity standards, have you seen any trends in who states are including in these panels?
Jen, do you want to handle that in relation to what the federal government may be advising?
So with respect to what HHS OCR has done, they came down on states very early in the pandemic with respect to age-based and disability-based discrimination. And basically, if you go through all of those filings, you'll find states altering their CSC plans in order to remove problematic language that could result in disparate impacts, discrimination on the basis of age or on the basis of disability. And there are a number of those available on the HHS OCR website that are available for review. With respect to the recent health equity task force, we are still continuing to watch that. The next plans for implementation is for the agencies to draw up their own plans, the departments to draw up their own plans on how they're going to adjust by that within 120 days of the October final report release. So we're coming up on that, and we'll certainly be watching for updates on that front.
Great points. And just one thing to add, and that is one of the neatest phenomenon that's been amazing throughout the course of the pandemic is how states have pivoted in their own CSC planning, that they have also allowed for hospitals to make, many times being very deferential to hospital-specific CSC plans. These are not static documents. They're being revised and reformed as we go forward. And a lot of states have made those critical sort of U-turns in regards to how they've approached these tough choices in reflection upon what and how they've impacted populations. So we're continuing to exist in that dynamic, and we're going to see a lot more of that effort ahead over the next 5 to 10 years after the pandemic as well. Great stuff. Erica, maybe time for one more question.
Yeah, we have one more question that is a request for comment relating to possible liability exposure by municipal EMT services, cutbacks, and refusals of service, even in cardiac events.
Oh, I like it because it's happening. We've seen it throughout the course of this pandemic. In a forthcoming article we have coming out in the Major Law Review, we'll be happy to circulate that very soon for your purposes to see. We actually discuss a little bit of this, and we talk about, Jen, I remember one great quote you had about EMS workers having to acknowledge they, unless they could revive somebody on site at one point in Los Angeles, they didn't take them to the hospital directly. It's fascinating, the implications for EMS workers in real time. And when there are circumstances in which patient outcomes are not favorable based on failure to respond in real time, could there be potential liability? We've looked at that actually with ASTO over time. Actually, pre-COVID, we looked at some of that with the Association of State and Territorial Health Officers in a report that's available. I'll be happy to share that with you. I think ASPR was also very heavily involved with some of that specific report. We looked at that systematically and found there's not really strong liability routes to actually challenging EMS workers, especially governmental EMS workers, that are implementing issues of this nature against the backdrop of limited resources and timing. So to be sure, what you're seeing there is not a solid pathway due to either sovereign immunity or other specific concerns about going after EMS workers that have to make really tough choices. And yet we know, of course, there are public and other members that are very concerned about what has not been done consistent with what they experienced in non-emergencies throughout the course of the pandemic. We're watching that phenomenon too on the liability front, but I can assure you there are protections in place to make sure that pathway does not lead to a lot of liability claims showing up at EMS stores for sure. Great stuff. Jen, anything to add in relation to what we commented on in the piece forthcoming?
No, not anything specific. I think you did a great job in summing that up.
Now, whoever asked that question, let me tell you, you see our emails on screen here. Ask Jen or me or Erica via email for access to that specific report through ASTO ASPR. I'll make sure you get it. It really does lay that issue out so nicely, and it's available online. Now, without further ado, Erica, I think we're right about that moment in time. Would you like me to go ahead and wrap up?
Yeah, sounds great. Thank you so much for all these great questions, and you've answered them so succinctly and well.
I thank our audience for being in tune with us on these specific issues. We know what you're facing and dealing with out there, and to be sure, we're ready to help and address through good information all of the specific concerns that you've been raising. And while we have only so much opportunity to address those through information that cannot, of course, extend into providing legal advice. Our promise to you is if you reach us back, let us know those specific questions. We've got tools and documents and things that can help, and Erica and Jen and I are committed to making sure to providing additional explanations. So a recording of this specific webinar for all colleagues that may not have been able to make it today will be available thanks to Charles at our national office at the network website you see there. Other additional documents, including that article and some other things coming out through our Western Region office very soon. Check back with us. We'll try to make sure you get that information. And to all of you, thank you for every effort you've done to save lives in the throes of this emergency using crisis standard of care as your backdrop. Without further ado, have a great afternoon or a continuation of your morning. Thank you for joining us.